Greetings and welcome. My name is Brad Monk. I'm so happy to be here for the evolving landscape in molecular-driven investigational therapies for advanced endometrial cancer. This is an industry-supported symposium here at the IGCS 2023 Annual Global Meeting. This is developed by Karyopharm in partnership with the GOG Foundation. I want to thank both teams. This presentation is for scientific and educational purposes only. Does not directly or indirectly promote or seek to promote Karyopharm's products or any other drugs for that matter. So I'm so happy to be here. I'm joined by my international key thought leaders. Keta, say hello.
Hello, and thank you for having me. It's my pleasure.
Thank you. The pleasure's all ours. And Rithu, say hello.
Hello, everyone. Thank you for having me here.
So grateful. This activity will be housed on the IGCS Education 360 website. It will also be housed on the GOG website for limited perpetuity. So if you have to step out or if you want to share it with your colleagues, we want you to have it in its entirety. Our learning objectives today are to talk about endometrial cancer clearly. And obviously, we now live in a molecularly personalized medicine world. We want to help all of us understand what biomarkers are and what they mean. And then we now have 4 positive trials in the first line, and we have ongoing trials, not only in the first line, but in recurrence. So we want to talk about what we know, but more importantly, what we're trying to learn. And so thank you. These are the agenda. All 3 of us are going to give a short presentation. We're also going to try to have some discussion. And again, we hope you find it useful. We've worked very hard, both the Karyopharm, GOG, as well as our speakers here to make this impactful and informational. I'm going to kick it off to talk about molecular profiling and a very brief overview of where we are, the approved therapies, and then ultimately Keta is going to talk about recent studies that have been reported, and then Professor Solani is going to help us and what to do next. These are my disclosures. They're also on the IGCS website. And I really want to focus on the molecular subtypes, and it's evolving. Not only is it evolving, but the staging system has changed, and the guidelines are currently changing. As you know, the NCCN guidelines were updated on September 20th, and we want to help you understand eligibility to clinical trials, because without clinical trials, we make no progress, and that's always our preferential treatment. So in the US, there are about 49,000 endometrial cancers. As you know, most are low grade, but there are some rare histologies, serous, clear cell, and carcinosarcomas. We're really interested in those patients ultimately that are at risk for dying, and so we want to go ahead and proceed and focus on that. Obviously, it's the regional and distant disease that are most concerning. So we have both the histologic subtypes and the stage, and that informs risk, and that informs treatment. So in the tumors that are localized to the uterus, we have an opportunity to follow algorithms basically that integrate a number of risk factors in addition to stage and histologic subtype. And those include age, actually. So I like this algorithm that was published in the Journal of Clinical Oncology now 4 years ago. Again, it follows and mirrors the NCCN guidelines. I think there is still a limited role for radiation in tumors that are limited to the uterus, and certainly in GOG 249, that has remained the standard. So I get it that we have sort of traditionally classified endometrial cancer into subsets. Let's just not do that anymore. I think histology still matters, stage matters, and even age and other clinical factors. But we are here to celebrate a decade of molecular profiling. The TCGA initially highlighted 4 subtypes: the POL, ultra-mutated, MSI, hypermutated, and then copy number low and copy number high. This has sort of evolved, and I'll get into it, but P53 mutation status is now very important. And TP53 is part of the copy number high group, but not all copy number high are TP53 mutated. And obviously the copy number low includes many grade 1 and endometrial driven tumors. So again, this is a decade old. It's still relevant. And it helps us partition into 4 different groups, but we're utilizing now this TP53 abnormal on the right and no specific molecular profile NSMP. Remember, we can evaluate TP53 with immunohistochemistry. You can also do it through next-gen sequencing. There's high concordance. The immunohistochemistry here, you see it's very dark. So how can it be dark, overexpressed, and still mutated? Well, the reason is that the protein is mutated, truncated, but it accumulates. And as it accumulates, the antigen, which informs the immunohistochemistry, is there and dark. If the early part of the gene is mutated, then it's null. The P53 wild type is what we call mottled, where it's sort of in between. So this darkly stained P53 mutated tumor, even though it's dark, it's mutated. And this has certainly been carried through in the NCCN guidelines in several iterations. And you see here that they're talking about P53 immunohistochemistry, and NSMP is part of that. So it's certainly POL, it's DMMR MSI, NSMP, and P53 wild type. And that's really the evolution of the TCGA. And obviously, germline testing can happen. We've learned, and we'll hear about it a little bit more from GY018, that most endometrial cancers are methylated in activation of the DMMR genes. And of those that are mutated, most are somatic. So maybe 10 to 15% are mutated, and maybe only 1 to 2% are germline, meaning Lynch syndrome. And so some people call this new molecular profiling the promise. I'm going to take an education point from Matt Powell, my good friend, who chairs the Energy Endometrial Cancer Committee. He calls it Promise Plus, because what's missing, and you're going to hear about it, is HER2. So Promise Plus integrates TP53 and HER2, and that is the state of the science. We'll get in because there's more to it, but I want to ask our panelists what else. DMMR MSI cancers, as you know, are found throughout the body. I think you're familiar how to manage that with immunohistochemistry. You can also do it through gene sequencing, and also just look at the microsatellites through PCR. And I'm happy to report, and the reason I'm happy to report that the most common MSI height, or the tumor with the highest prevalence of MSI or DMMR, is endometrial cancer. Why am I happy to report that? Because that's where checkpoint inhibitors work the best. It doesn't mean they don't work in the pMMR subset. We're going to get into that, but that's why we're here to have and talk about the first immune therapy that was FDA approved on July 31st and had a positive CHMP opinion on October 12th, which is Ruby DMMR. So it is an international opportunity. We've seen in some of these tumors, this is a small subset that suggests that the mutated genes have a different activity or a different neoantigen load, at least, than the methylated tumors. We've also suspected that the methylated tumors are easier to revert and develop resistance. We're going to show you some data, or at least discuss some data, how this is or is not true from the 4 trials now that are reported. I don't really care. I do care, but I don't think it really matters how you test for DMMR. In the Ruby trial, you could do any of the 3. You could do PCR, you could do IHC, or you could do next-gen sequencing, and they were all lumped together, and it was investigator-assessed DMMR. These are just some labs. There are others. I think it's fairly straightforward how to test for these, and it probably doesn't really matter. There is overlap. There is overlap between MSI DMMR, TMB, and PD-L1, and we used to say that PD-L1 doesn't matter, expression. Well, it does matter. And we're learning that as these 4 pivotal trials are reporting, but there is overlap. When there is MSI or DMMR, there's a greater T cell infiltrate. And when there's a greater T cell infiltrate and there's an increased PD-L1 expression, and that leads to a greater activity. So now, thank you to Dr. Barrick, Professor Barrick, one of my mentors. The endometrial cancer staging system has changed. It now integrates, as you see here, the molecular profile. And again, the molecular profile is not only prognostic, meaning that some patients do better, but it's also predictive, meaning that some interventions are more active. So again, we're here to celebrate a decade of the TCGA. Congratulations. But we're also here to celebrate the activity of immunotherapy, which began with the tumor agnostic approval of pembrolizumab, but it's way more than that. It's now dostarlimab, it's pembrolizumab, and now it's the frontline Ruby DMMR approval, and it will undoubtedly be more approvals as the additional studies report and are filed. Now, in the second line, we're not going to spend very much time talking about it. We are all familiar with Keynote 158 and Garnet, that these were very similar response rates of 46 and 48%. And we're also very familiar, Professor LaRusso is going to get a little bit more into this, but there is a 5.8-month improvement in overall survival when pembrolizumab is used in the PMMR subset second line. This is an update. Remember, 309 Keynote 775, the first report was interim analysis 1. This is now final. There's more than a doubling of the response rate, a hazard ratio of 0.7 for OS. So that's one of the big controversies today in the PMMR frontline. You say, look, I'm not convinced that triplet chemotherapy IO works in the PMMR. I'm going to save it for second line, which has a 5.8-month improvement overall survival. So this was just published in the JCO. It begins to integrate everything that I've said, okay? And it adds the next biomarker, which I'm not going to get too much into, but estrogen receptor. Estrogen receptor and progesterone receptor not only is differentially expressed, but it also informs the activity of ER or CDK4/6, but it's also prognostic. So this is the evolving, and I want you to refer to this because hormonal therapy is a real thing, and we need to study it more. So thank you. I hope you enjoyed that. Again, I want you to have these slides in the video, and I always share my slides. I want to begin a discussion here. Maybe Rithu or Professor Slime, we call you Rithu. We've known each other for a long time, if that's okay.
Absolutely.
Living in Los Angeles, what do you see being done in the community, or have they all adopted the testing? So 2 questions: what's right and what's being done for testing in Southern California?
So I would say that standard is mismatch repair testing. And I think that can be done with IHC at most institutions. I think that not only informs potentially the treatment paradigm, but also genetic testing for some of our patients. And I think that ER/PR status should be the bare minimum. I also think you've alluded to many of the other markers that we should be testing. I think POLI is kind of the ideal panel. I don't think we're quite there yet for universal testing, but I think that's something that's really close on the horizon. HER2, which will also have implications. And then the other one that I think should be incorporated at the time of diagnosis is P53 mutation status. So that would be my kind of dream panel to include all of those, but I think mismatch repair testing, ER positive, and now P53. What I'm seeing kind of around the community varies. I would say most places are doing mismatch repair testing, but it's not universal yet. And that to me is a little bit alarming because that can have a lot of implications clinically. So I do hope we get there. I think ER/PR is pretty routinely done, at least I'm seeing it on most pathology records. The rest of it, I would say, is very uncommonly performed.
I've just returned from ESGO, as you guys have, and ESMO, and now we're here at the IGCS. I've learned 2 things. Just what you said, of course. The first thing that I learned is that if you're going to do a surgery on a young woman and preserve the ovaries, you better make sure that she doesn't have Lynch syndrome. Isn't that interesting? And I give Dr. Wilmont, who saw one of my pre-ops, credit for that, she said, oh, you don't know whether this woman has Lynch syndrome or not. And so while the patient was getting set up for surgery, she figured it out. The second thing that I learned is that the best time to do the molecular profiling is on the endometrial biopsy. I said, why? She said, you know why, Monk? I said, no, I don't. That's why I asked the question. Why? They said, because when you do a hysterectomy, it sits on the back table, okay, and doesn't go to pathology. But when you do an endometrial biopsy, you do it and you turn around, you plop it in the formalin. And so the quality, the fixation for the immunohistochemistry is of a higher quality for the endometrial biopsy. I'm like, oh, that makes sense. Interesting, right? Now, Keta, the staging system has changed. I gotta say, as I talk to my friends, they haven't really adopted it yet. You guys are early adopters. You have ESGO guidelines. What's the status of this new staging system in Europe?
You know, Brett, it's the publication is 1 month and a half ago, so it's a very recent publication, and it will take time to enter in clinical practice. Also because it represents a huge change in paradigm. So for the first time, we will not classify according to the organ borders, but according to the biology of tumors. So it will take time to be uptake, but I think it's a huge step forward in the classification of our patient, and personally I am in favor.
Yes, thank you. In Europe, is TP53 and HER2 routinely done, or is it more DMMR ER, which is the minimal standard that Rithu mentioned?
No, we implemented in our guidelines, but also in our practice, we implemented all the biomarker that can be done by immunohistochemistry. I mean, ERPR, P53, and the MSI high and the MMR, but in immunohistochemistry. The bigger hospital also implemented POLI, which is an NGS test, and so probably not so wide available as immunohistochemistry.
You know, you and others have been big leaders of the ENGOT-GOG collaboration, and what this has really created is just what you said. It's not a US standard, it's not a European standard, it's not an Asian standard, it's a standard. And so we're happy to be here in Asia. There's sort of a right way and a wrong way to do things, and I'm glad that we have consensus and we agree, and I'm excited to hear new data presented at this meeting. So, Keta, I'm going to turn it over to you to talk about some clinical trial data. Again, we've just returned from ESMO, and there'll be new data at this meeting. So take it away. Thank you.
Thank you, Brett. This is my declaration of interest. And as Professor Monk reported, up to 31% of endometrial cancer patients present microsatellite instability for all the reasons that he mentioned: TMB, increased PD-L1 expression, increased tumor-infiltrating lymphocyte. This tumor, by definition, respond quite well to immunotherapy. In fact, when we use immunotherapy agent as a single agent in MSI-high patient, up to 50% overall response rate was reported. And it is incredible because when a patient respond for a very long time, 84% of patients were still in response in Garnet trial at 2 years from starting treatment. But the second lesson that we have learned is that when we do not select the patient according to the DMMR, the response to immunotherapy single agent is quite low. I cannot say that immunotherapy does not work in the pMMR population, because, you know, this is exactly what we obtain with chemotherapy, and we use chemotherapy every day for our patient. But the sensation, the feeling is that we can do more. And we can do really more. And in order to leverage immunotherapy activity, we try to combine. The first combination was with anti-VEGF agents. There is a strong rationale in combining anti-VEGF plus immunotherapy because of the crosstalk between immunotherapy microenvironment and anti-angiogenesis. And the Keynote 775 that Professor Monk mentioned was the first randomized trial evaluating pembrolizumab, lenvatinib versus physician choice chemotherapy in a population with advanced or recurrent endometrial cancer who had failed at least one prior platinum-based treatment. And the trial was incredibly positive, both in the pMMR and the all-comer population. The two primary endpoints were met, and the significant increase in progression-free survival, about 4 months increase in progression-free survival, up to 6 months increase in overall survival were reported in favor of pembrolizumab lenvatinib. For sure, we have never forget that endometrial cancer patients are different from cervical cancer patients and from ovarian cancer patients. These patients are older. They have a lot of comorbidities, including hypertension, obesity, diabetes, cardiopathy, and for this patient, the toxicity profile of the combo need to be carefully evaluated, because in the registrative trial, where by definition we include the best patient we have, up to 66% of patients did need dose reduction, and up to 33% of patients discontinued the treatment because of an adverse event. We need to be simply prepared to manage the adverse event. In 40% of patients, grade 2 or higher hypertension was reported, diarrhea grade 1, 2 in up to 60% of our patients, and also nausea and decreased appetite. All this requires a learning curve in the management of side effects, require that we dedicate effort and time to follow our patient, but for sure, this is a combo that increases overall survival in second line, so we cannot miss to provide this to our patient. The second combination we manage is the combination with the chemotherapy. This year at SGO, we saw the presentation of two practice-changing trial that for the first time combined immunotherapy plus platinum-based chemotherapy in the first-line setting of advanced disease. The RUBY Part 1 trial combined dostarlimab to carboplatin paclitaxel in a population with stage 3, 4, and first recurrent endometrial cancer patient. The trial met its primary endpoint, and a significant and clinically extremely meaningful increase in progression-free survival was reported with the combination of dostarlimab plus chemotherapy in the dMMR population, where an hazard ratio of 0.3 was reported, but also in the overall population, an hazard ratio of 0.64 was reported. And as Professor Monk anticipated, actually, the drug has been approved for the dMMR population. There is a trend in overall survival. Overall survival is not yet mature, but there is still a trend positive in terms of overall survival with an hazard ratio of 0.64 that suggests that probably also overall survival will be increased by this patient. And last week in ESMO, we saw very interesting subgroup, not pre-planned analysis that evaluate the role of immunotherapy according to the molecular profile, because particularly in the pMMR population, that is an extremely heterogeneous population, as Brad reported in the first lecture. And very interesting, a significant benefit in terms of progression-free survival was reported with immunotherapy in the P53 mute patient. It was reported also, as expected, in the dMMR population, but less clear benefit in the non-specific molecular profile group, neither for PFS, neither for overall survival, thus suggesting that probably this population potentially may require different strategies, but again, unpreplanned exploratory analysis. At SGO, a second trial confirmed the huge benefit of immunotherapy in combination with platinum-based chemotherapy. The GY018 Keynote 868 combined pembrolizumab to carboplatin paclitaxel in quite the same population, recurrent or advanced stage 3 and 4A or 4B endometrial cancer patient. And also this trial reported a huge benefit of pembro in combination with platinum-based chemo with an hazard ratio of 30 in the dMMR population, but also in the pMMR population, another ratio of 0.54 was reported. This trial had alpha allocated in both the populations, so the result is reliable and clinically significant. Last, combination. We try to evaluate, in order to leverage the indication of immunotherapy, the combination with PARP inhibitor. Also in this case, there is a huge rationale in the combination because the genomic instability produced by PARP may only benefit from immunotherapy. And there have been 2 phase 2 trials evaluating immunotherapy plus PARP and reporting 11% and 16% overall response rate, which are interesting, but probably not so particularly exciting. But they were enough to move forward with the 2 randomized phase 3 trials, the Ruby Part 2 and the DuoE. And 1 week ago at ESMO, we saw the results of the DuoE that for the first time introduced PARP inhibitor in the treatment of endometrial cancer. The trial was a randomized phase 3 trial comparing carboplatin paclitaxel chemotherapy or carboplatin paclitaxel chemotherapy plus immunotherapy durvalumab, or carboplatin paclitaxel chemotherapy plus durvalumab, followed by durvalumab olaparib in a population of stage 3, 4, or recurrent endometrial cancer. Very interesting. The statistical design of the trial was a comparison between the 2 experimental arms and the control arm, and the trial was not powered to compare the 2 experimental arms each other. Nevertheless, the trial is incredibly positive, and a significant increase in progression-free survival was reported for both the 2 experimental arms with respect to the control arm. And even though overall survival is not yet mature, a trend toward an increase in overall survival was still appear in these curves for the 4-drug arm combination with respect to the standard arm. Very interesting, the colleague provide several subgroup analyses in order to evaluate if they were able to identify some predictive biomarker that further guide clinician choice in the best treatment. And it seems that the benefit of the combination of PARP plus immunotherapy is relevant in the pMMR population, where for the dMMR population, the addition of olaparib does not modify with respect to durvalumab. I'm not surprised by these results. The bar in the dMMR population of immunotherapy plus chemo is so high that it's very difficult to further increase. But for the pMMR population, a significant benefit was reported with the 4-drug treatment. But very interesting, for the first time, I have to say, in endometrial cancer, another biomarker came. PD-L1 positive tumor, according to the TAP more than 1% test, seems to be a predictive biomarker of response to immunotherapy, but also to the combo of immuno plus olaparib. This is a new, I have to say, biomarker in endometrial cancer that, in my opinion, require further exploration because literature data are not so consistent in the evaluation of PD-L1. It changes according to the test we use, to the cutoff we use. So we are probably more in favor or identify molecular biomarker in this moment than PD-L1. Anyway, the future will be rewritten very soon.
Thank you. That was very comprehensive and very thorough. One thing that you didn't present, and I realize that we're time restrained, is this idea in GY018, Iskander compared mutated versus methylated. Tell us a little bit about that result.
You know, Brad, there were inconsistent results about that. The MSI high may derive from 2 different pathways. The mutation of MMR gene, either germline or somatic. If germline is the Lynch syndrome, but also somatic may play a role. and this represents a minority of the patient, less than 10%. The majority of the patient present methylation of MLH1. So there were some suggestions in two pembro small trial, 18 and 25 patients. There was a suggestion that if there was a deficiency in the genes, either somatic or germline, the rule of pembro was higher, and the benefit of patients with germline or somatic mutation in MMR genes gain major benefit from immunotherapy. These data were not confirmed in the Garnet trial, and again, it not be confirmed very recently at the presentation of GY018, in which methylated and unmethylated patients gain the same benefit of immunotherapy. So that's a clear message now. Regardless, methylation or mutation, patients with MSI high tumor benefit gain a huge benefit from immunotherapy.
Yeah, thank you for that. Ritu, I always thought that the mutated patients had a better benefit from the data that I showed. Do you look at the methylated and the mutated patients the same, or how do you approach it?
I think to Keta's point, I think we clearly know that immunotherapy has a benefit for these patients. So I don't think we need to distinguish, you don't need to piecemeal it that much. It may have a difference in, duration of response, prognostic, but I don't think the question of immunotherapy exists in whether you're DMMR or methylation driven. So I think it's clear that, checkpoint inhibitors are here to stay in that population.
I think that's another key discovery that we're at least learning about from ESMO. DUO-E, and you presented it very well, Keta, thank you so much. It's interesting that they didn't carve out DMMR. So as you know, in the Ruby, it was DMMR intent to treat. 18, it was separate cohorts, and then DUO-E just threw them all together. Do you think that's going to create regulatory challenges because the DMMR was not called out as an analytic endpoint, or do you think it's going to be like PALA-1, where in PALA-1, we just got HRD approved for olaparib bevacizumab because PARPs work? What's your opinion? I know that's a tough question, but
yeah, it is tough. And, sometimes predicting what these regulatory bodies does is, anyone's guess, but I do think it's going to create regulatory issues. I think there's a couple of, as we kind of get more information from other trials, I do think it's going to create issues. I also think the addition of a PARP inhibitor in this landscape is tough, right? This is a tough population. And although I think the data is very provocative, I'm not sure that this is ready for prime time.
Let's take it to even a higher level, Keta. So PMMR is a subset. Comparing arm 2 and 3 is non-analytic. And then you're like, well, PD-L1 matters. So that's a subset of a subset of a subset. Is that problematic, or you say, look, it follows the biology, and I'm convinced?
To be honest, I would like to have more information about who are the PMMR patients that really can benefit for a 4-drug combination. Yeah. Because I agree with Ritu, these patients are fragile. 4-drug, it's not easy to manage. But looking at the forest plot the colleagues presented, and in the interest of time, I cannot report here, it seems that the patient with HRR genes mutation may gain more benefit for the 4-drug combo and PARP inhibitor, which is not surprising to me. These are the same patients that gain benefit in ovarian cancer, so I would be not surprised. But this should be confirmed. But if this is true, this means that our molecular profile will add another biomarker, which is the HRD, or at least the HRR.
Yeah. There's been lots of controversy and, quite frankly, disagreement between the European Medicines Agency and the Food and Drug Administration regarding the survival issue and the activity of subsequent therapy in ovarian cancer. Now, endometrial cancer don't get the same numbers of therapies. I guess they could get treated with platinum after platinum. Ritu, again, I know we can't predict, but do you think that there might be a situation where PARP inhibitors would make subsequent, let's say, platinum less active in endometrial cancer, if that becomes a thing, like the suggestion in ovarian cancer, or you just don't believe it categorically? What's this idea of survival in PARP inhibitor therapy? Does that translate into endometrial cancer?
Yeah, I mean, as we're seeing more and more data and, seeing certain labels being withdrawn based on, kind of non-analytic endpoints, I think it's an interesting question. And I do have concerns that, PARP is kind of like a platinum surrogate in regards to the resistance pathways. So I do think it makes sense, but I would just hate to say that as a broad statement because we just don't have that data, particularly in endometrial cancer, where, I'm excited to talk about what's coming up on the horizon, but generally there's been a paucity of options for these patients. And so now that we have multiple options, I think it's exciting. And where PARPs are going to fit in, I think Keta brings up a great point about the HRR genes and, the BRCA mutation patients. That might be a specific niche for these patients, but I'm not sure that this is ready for broad label.
And you know me, I'm not going to ask you guys easy questions. Seriously? Why would I ask you guys an easy question? So this is the fun of the conversation. And so I'm gonna give you another zinger, Keta. You did a brilliant job of perhaps one of the most transformational studies, A18, another ENGOT-GOG collaboration at ESMO. This is an endometrial cancer conversation, but I invite you to look at those data, and ultimately will undoubtedly lead to regulatory approval in many countries. I was the discussant for that. It was my honor. And we started to talk about the class PD-1 versus PD-L1. Again, nobody knows. Again, this is not an easy question. When you compare sort of PD-L1 DuoE to PD-1 dostarlimab, pembrolizumab, are you seeing any differences there? Again, cross-trial comparisons inappropriate, but there will likely be a day that we will have PD-1s and PD-L1s approved in the same tumor type in GYN, maybe not. But if we do, how do you assess those differences? Is it cost? That's really what matters. How do you break that down?
Looking at the future, this is really a $1 million question, but I will tell you my opinion. When you have a dMMR patient, the biomarker is so strong that whichever drug you use, it works very well. Look at all the data, all the trial we have in the dMMR population. PD-1 and PD-L1 works exactly in the same way. But when you have a pMMR population, so a population with the oncogenic driver which is not so strong, probably the drug we are using played the difference. If you look at the data, the ATTEND trial with atezolizumab in the pMMR population, atezo did not work. While pembro work, dostarlimab works. So probably the choose of the drug may play a role when the oncogenic biomarker is not so strong.
Very insightful. Thank you. All right. So the future is important because we change it. You change it through the clinical trials that we enroll around the world, and personalized medicine and biomarkers are important. So Ritu, you've prepared a very nice talk for us, and we're excited to hear it. Go ahead.
Thank you. All right. So here are my disclosures. And just to kind of remind ourselves that, we always hear this myth that endometrial cancer is a good cancer. And we know that that's clearly not true when you present in the advanced setting. And when you look at kind of studies across the board, varying studies, but looking at the control arm, median PFS is about 8 months for these patients, and 80% of these patients will recur within 2 years. Now, these are the advanced cohort, but these patients continue to present a dilemma. And this is a slide I adapted from Dr. Moore, Katie Moore, so thank you to her. But overall survival in the mismatch repair proficient is about 30 months. So when you look at the advanced and recurrent cohort, you can kind of see where we started in 1992 with our classic chemotherapy regimens to now where we are with the addition of checkpoint inhibitors. So we're making progress. And although the mortality for endometrial cancer has been rising, I honestly feel like some of these studies are going to start, curbing that trend and even reversing it. But what I really want to focus on is where is the future? And so I want to provide you an overview of the clinical trials, particularly looking at the MMRP and P53 wild type, since we just had these new advances in the deficient population. So I think we're making good progress there. So let's look at the other cohorts. So before I do that, I just want to kind of be provocative and just say maybe there's a role to eliminate chemotherapy in the mismatch repair deficient cohorts. And these are two trials, Keynote C93 and Dominica, which are looking at checkpoint inhibitors versus chemotherapy, platinum and paclitaxel. And so these trials are, I think, going to help be informative, although some will argue the control arm is not ideal, but I think this is an opportunity. Additionally, there's Keynote B21, which is looking at pembrolizumab versus chemotherapy with or without radiation in endometrial cancer, looking at different cohorts, kind of early stage and advanced stage, but all high risk, and kind of adding to the Keynote 868 or GY018 study. And then LEAP-001 is looking at both mismatch repair proficient and deficient, and looking at the combination of pembrolizumab and lenvatinib versus chemotherapy. So all of these trials are really looking at the role of checkpoint inhibitors a little bit further, and potentially even eliminating chemotherapy. So very exciting, but still need to see this data. But I want to move on to like the next steps. So when we have advanced or recurrent endometrial cancer, we know these patients have that high recurrence risk, and their overall survival can be impacted. And so there are a couple of studies I just want to highlight. Here's GOG 3089, which is looking at navtemadlin, which is a p53 wild type study. So patients with advanced or recurrent endometrial cancer with p53 wild type are going to be randomized to navtemadlin, different dosages versus observation. And the reason why this study is interesting is this is a maintenance trial. So after platinum-based chemotherapy, it's looking at this oral MDM2 inhibitor. And the goal of this is to actually restore p53 activity and result in cancer cell death. And so it's a very provocative trial. It's early, but I think it's something that you want to keep your eye on. And in that same fashion, I want to focus on SIENDO trial. This is a study that has been reported, and I just want to kind of go over some of the details because I think this is a really exciting area that's going to maybe target some of these areas where we have some needs. So this study randomized patients after platinum-based chemotherapy with paclitaxel and platinum and paclitaxel. Patients had advanced disease or primary or relapse. And these patients were randomized to selinexor at 80 milligrams once weekly or placebo. And the primary endpoint was PFS. And these patients could not have received prior PD-L1 or PD-1 inhibitor therapy. And the reason why this is important is selinexor is an XPO1 inhibitor. And what this does is allows it reactivates the tumor suppressor proteins within the cell and allows for selective cell death of these cancer cells. And so this is a really exciting target, once again, looking at that p53 wild type cohort. And before I talk about the results of the SIENDO trial, I just want to highlight some of the patient characteristics. You can see there was a wide variety of histologies. Most of these were endometrioid, but you can see there was high-risk histologies included as well. The p53 mutation status, this was in all comers, and you can see about 40% were wild type and about a little bit over 40% were mutant. And then the last category that I think is interesting is the microsatellite instability or MMR status. And you can see, as expected, over 60% were mismatch repair proficient, and about 15% were mismatch repair deficient. And then here are the results that were initially presented and published in just this year in 2023. And if you look at the intention to treat population, selinexor versus placebo really didn't have a notable impact. You can see that the hazard ratio is 0.71 with the audited hazard ratio. But what really stood out is when they looked at this pre-specified cohort of patients who had p53 wild type. And what they saw here is that the patients who received selinexor had a 13.7-month progression-free survival versus that placebo of 5.2 months. And you can see this hazard ratio is 0.41, and this was statistically significant. It's always important to recognize that adverse events can limit therapies, and this therapy was generally pretty well tolerated. You can see that there were some hematologic toxicity, some nausea, but what I do want to highlight is that with dose reductions and dose interruptions, the discontinuation rate was pretty low at about 10%, and longer-term data, this was about 16%. So generally acceptable or manageable toxicities that we saw. And then here you can see the long-term follow-up, and this was just presented by Brian Slomovitz this year at ASCO. And here you can see the long-term follow-up, particularly looking at that p53 wild-type cohort. No difference in that mutation cohort, but in the P53 wild type, this was a pre-specified analytic cohort, 27.4 months versus 5.2 months with a hazard ratio of 0.42. And you can see these survival curves clearly show a difference. And this is something that I think is really compelling. They also looked at this in the mismatch repair cohorts. So the mismatch repair deficient cohort, you can see a 13.1 versus a 3.7 month progression-free difference or outcomes with a hazard ratio of 0.45. So although this did not have statistical significance, there is some clinical relevance here. But in the P53 wild type proficient population, you can see that it's even more pronounced. The median progression-free survival had not been reached in those patients randomized to selinexor and was 4.9 months for those in placebo. So I think this is really exciting data. And because of this, it's being carried out further in the Export EC042 trial. This trial is ongoing, so I hope that you have it open at your site or have a site near you that you can enroll patients on this trial. Once again, looking at endometrial cancer stage 4 or recurrent endometrial cancer with P53 wild type molecular profiling, and patients must receive platinum-based regimen prior to, but the one difference is it's now allowing for prior IO therapy. So this is one of the big changes from the SIENDO trial. You can see here the primary endpoint is PFS and the secondary endpoint is OS, and patients will be stratified based on whether they're primary or recurrent disease. One other thing to note is the selinexor dose is 60 milligrams, so a little bit lower than what was studied in SIENDO, and this will hopefully help mitigate some of the adverse events and help keep patients on trial drug. So as we anxiously wait for these trial results, I want to talk about what's coming, what's kind of also on the horizon, and how can we think about sequencing our treatments that we have. So you've seen this is from the NCCN guidelines, and I just want to kind of highlight, I think with the DMMR population, when we have advanced disease, we know that chemotherapy is kind of the backbone as of today. And with the DMMR population, this is now going to be inclusive of checkpoint inhibitors, followed by maintenance checkpoint inhibitor therapy. In the P53 aberrant group, we're still exploring options for these patients. There may be a role for checkpoint inhibitors in these patients, even without the DMMR mutations as shown by Keta. And I think the other population that we've kind of touched upon is that HER2 population. Should we be combining chemotherapy with trastuzumab and then doing trastuzumab maintenance? And I think that's something that we're continuing to explore. The nonspecific mutation profile is the selinexor study or the NAV to Madeline study, which is looking at that P53 wild type cohort. And so I think these are all, we have kind of strategies for all of these patients. I do want to highlight that in the checkpoint, in the DMMR population, if these patients recur, they may be able to be re-challenged with chemotherapy and then be a candidate for the Export EC trial as well. So I think sequencing is really important, and I think finding the best therapies up front is going to be really key. But we need to continue to explore different options. And this is a slide that I actually stole from Brad Monk, so I thank him for this. But looking at where else we can go, and we've talked about kickstarting apoptosis with the P53 wild type cohort, and I want to explore these other options just very briefly. So endocrine therapy, I think this is an area that's been around for quite some time. We've really reserved it, at least in the United States, for fertility preservation or palliative therapy. But I think this is really playing a significant role that we cannot understate. We're seeing studies looking at combination of mTOR inhibitors and aromatase inhibitors. We saw data that showed a response rate of 24%, really a comparable response rate to chemotherapy if the patients were initially treated with this, but a significant clinical benefit rate of 78%. And then also now something that's being studied after the data in breast cancer is the combination of aromatase inhibitors and CDK4/6 inhibitors. And you can see the paleo data and abemaciclib and letrozole, which show kind of response rates of about 30%. Disease control rates may be even higher when you include those patients with stable disease. And I think this is a really interesting area that we need to explore. One thing I struggle with is how do we define estrogen progesterone receptors? You know, what's positive and how do we parlay that into treatment? Next, HER2. So HER2 has been considered a negative prognostic marker. We know that it's prevalent in uterine cancers and most prevalent in uterine serous carcinomas. These curves here that are shown are from kind of prospective data looking at the addition of trastuzumab to chemotherapy. And you can see that there was a a PFS benefit in those patients with advanced disease who received trastuzumab in addition to chemotherapy. And this was really seen in that primary setting. And this, I think, has generated a lot of excitement. There are trials being developed that are ongoing. And I think in the interim, we've seen some really exciting, compelling data with trastuzumab ADCs. And just at ASCO and then kind of longer-term data at ESMO, we saw data about trastuzumab deruxtecan, which was a Destiny Pan-Tumor 02 trial. This trial looked at patients who had HER2 expression, really focusing on those with high expression of 2 to 3+. The endometrial cancer cohort was limited to 40 patients, and you can see the really impressive results here. Patients who had HER2 3+ had an 84% response rate. When you look at all comers, it was 57% response rate. And at ESMO, they just reported that the median at, they had 12 months of follow-up, had still not been reached for those patients who had received this in this cohort. So really provocative data, and how this pans out, whether this gets kind of HER2 expression approval across tumor sites is yet to be seen. But I think it's something that we're probably going to be wanting to keep our eye on. And endometrial cancer is not the only GYN cancer. As a matter of fact, we saw results in ovarian and cervical cancer in patients with HER2 expression. TROP2 is another target that's really gaining a little bit of steam. So this is overexpressed in endometrial cancer pretty ubiquitously, and you can even see high expression in about 2/3 of patients. And so this is another area that's being further developed, and I want to focus on some of the data that was presented at ASCO this year. What I really want to highlight here are these were patients who had prior treatment. So you can see in this first side of the slide on the left side, median of 3 prior treatments. And we saw objective response rate with a TROP2 ADC of 33% and a durable disease control of greater than 6 months and 35%. You can see the median PFS of 5.7 months and overall survival of 22.5 months in a heavily pretreated group. So this is really exciting data. And then TROPICS-03, which is an endometrial cancer cohort, about 2/3 of these patients had prior PD-1 or PD-L1 therapy. This is a small group of 20 patients, but a beautiful waterfall plot curve here with patients having partial responses or stable disease deriving some clinical benefit at about 35%. So this is being further developed, and I think this is an exciting area. So, I think one of the things we all struggle with is now that IO is moving up to the front line, how do we manage these patients? And I think we have lots of options. And then lastly, folate receptor alpha inhibition. We are already using this in ovarian cancer, and in endometrial cancer, we see about, once again, 64% patients with endometrial cancer have overexpression of folate receptor alpha. And you can see that there are some ongoing trials that hopefully you can enroll in as well, because I think this is an important question to answer. So in conclusion, my takeaways, I don't think I can highlight enough that molecular profiling is critical. And now we're seeing kind of even further breakdowns so we can provide the best treatment to our patients. I'm really excited about maintenance strategies. I think eliminating, chemotherapy or long-term, we used to treat until progression with chemotherapy, and now maintenance strategies, I think, are an important option for our patients. And I'm really excited about other emerging therapies with novel targets that we've never used before in endometrial cancer. So I'd like to thank you.
Thank you, Elite. Beautiful slides. Took a lot of work to put all that together in very short notice. So thank you for that. I hear a lot of people talk about, how common is P53 wild type? And you said, well, it's about 40%, but there are a number of patients where it's unknown, probably. So 50%, I think that's an important message. I also like that you highlighted in Export EC that if you got triplet therapy, chemotherapy checkpoint, you get carboplatin again. And if you responded and were wild type, you could go on navtemadlin or selinexor or phase 3. What do you think the response rate is of reinduction with carboplatin paclitaxel? Does the platinum-free interval, I'm going to ask this to you, Rithu, does the platinum-free interval matter? Or is really the control arm, weekly paclitaxel doxorubicin that was used in Keynote 775? Tell me about this reutilization of carboplatin paclitaxel and what the expectation is as you explain that to patients.
I definitely think that platinum and paclitaxel are patients should be considered for rechallenge. I think it's probably one of the more active agents we've had. I think one could argue that in lenvatinib pembro keynote 775 that the control arm was maybe weak, and that's why we see such a and I think it's a great approach for our patients, but I think the control arm leaves a lot to be desired, and I think rechallenge with a platinum-based regimen makes sense. I do think the interval matters though, and once we see further breakdown from GY018 and Ruby, which it did allow for recurrent patients and rechallenge with platinum-based chemotherapy, I think that we'll understand a little bit more about this, but I think it really makes a lot of sense. I've read some retrospective data that carboplatin paclitaxel rechallenge is probably equal, if not, I'll just say equal to lenvatinib and pembro in the recurrent setting, and maybe toxicity profiles and tolerability, familiarity all matter. So I think it's a really important option that we should not discount from these patients.
Yeah, and I get asked all the time, well, listen, Monk, what are you going to do after triplet therapy in the front line? Well, you just told me. I'm going to give them carboplatin and paclitaxel, and if they respond in a wild type, I'm going to enroll them on this clinical trial. There's very little data of checkpoint after checkpoint, and I get that, and we're probably not going to have time to get into that. Keta, and again, very nice presentation, Rithu. You got 3 trials now that have completed enrollment in the front line: C93, de-escalation, pembro; Dominica DMMR de-escalation to dostarlimab, and then LEAP 001, again, now PMMR, comparing it to carboplatin paclitaxel. How are you going to sort that out now, Keta? Because you told us in the PMMR subset, particularly for GY018 and Ruby, we're probably going to have an approval. So it's nobody's fault. And when those studies were designed, we didn't know that, but the control arm has changed. How are we going to sort out the results if they're positive of C93, Dominica, LEAP 001? Because the control arm today really is not carboplatin paclitaxel, it's carboplatin paclitaxel IO.
Brad, another 1 million question. The problem is that in this moment, clinical research is so fast, but so fast that when we design a trial 4 to 5 years before, we cannot be so visionary to try to understand where we will be 6 years later. And you are right, neither of this trial has the proper control arm, because now Ruby, GY018, Attend, and also DuoE defined a completely different standard arm. Nevertheless, I think that the question of chemo-free treatment still remains important for the patient, because if I'm a patient, I would not be so confident in receiving chemotherapy. If I have an alternative, I would love to do something which does not contain chemotherapy. What is important, in my opinion, even though we do not have head-to-head comparison between the strategies, I think that actually we have some instrument that can make indirect trial comparison reliable. Thinking about Dominica or C93 or Ruby or GY018, these refer to the same population. And all this has the same control arm. So there is a way to perform indirect, high-level patient data indirect comparison to try to have at least an idea of what is the best treatment for this patient.
Very, very thoughtful. So, Rithu, we're going to end on the diversity issue. So diversity matters in 2 ways. One, the types of patients that get these cancers, it's not the same. So I'd like you to address that. And it also probably informs the activity, particularly in Asians. So talk to me about this idea that we need a diversity plan in all of our trials. Number one, why that's important, the type of cancers that various ethnic groups get. And then, Rithu, tell us also whether it should be considered in the treatment decision.
Yeah, it's a great question. And we did see some, interesting data where the, just kind of speculative, where maybe certain cohorts, particularly the Asian cohort, maybe didn't have as pronounced of a response to PD-L1 inhibitors. And understanding that, I think, will be really important. But I think this really highlights the issue of having diverse populations, because we may be tossing out therapies that have benefit in certain groups, but not in other groups, without really recognizing that or approving therapies that have benefit in one group, but not other groups, because those are the patients who enrolled on the clinical trial. And so I think having a representative population of the patients we see with the disease is so critical. And what I'm really excited about is, when Keta had shown the P53 mutation patients potentially having a benefit from IO therapy, even despite the lack of a mismatch repair deficient, we know in the United States that represents a high group of underrepresented minorities who fall into that category. And so having an option for these patients where we haven't had really good therapies, but we need to continue to advocate for patients who are diverse, who represent the diseases that we're treating, being put on these clinical trials. And I'm so pleased that the FDA is kind of making this a mandate, that GOG has great initiatives to promote diversity, patient advocacy groups. I mean, I think we know the issue, and now we have some direction to help address it.
It's really challenging to sit in front of a patient of an underrepresented minority, and you really don't know what the activity of that new opportunity is because it wasn't studied. So I appreciate you highlighting that. So, Keta, I'm going to give you the last word. Tell us and critique what Ritu talked about, sort of the future. What are you most excited about as we move forward and complete and ultimately read out these clinical trials?
Brad, in Seoul, in less than 1 week, we will have the first endometrial cancer consensus conference on clinical research. I am really excited about the idea to move forward from this kind of dinosaurus trial in which all the patients are put together, and probably in this way we will not move forward. So endometrial cancer, as Ritu say, endometrial cancer has several biomarkers. We have to move with the idea that next trial in endometrial cancer will take in consideration the biomarker, and we will design biomarker-driven trial. All these data are exciting, but all this data did not recognize the difference in the population enrolled according to a predefined biomarker. Mm-hmm. And I think that for the future, we have to design trial for HER2 positive patient, for TROP2 positive patient, from HRR mutated patient. So this is the way to move forward, in my opinion.
Yeah, thank you for that. So I want to thank you, Ritu Salani. I want to thank you, Keta LaRusso, for being with us. I want to thank Karyopharm for supporting this. I view this as a very fair and balanced educational discussion. I want to thank the IGCS for allowing us to put on this program, but I also want to thank the individuals behind the scenes, the individuals who you don't see, the Lindsay Mollers of this world, the Jenna Cummins of this world, who are both part of the GOG Foundation educational opportunity. Those are the individuals that caused the rubber to hit the pavement and allowed this to happen. So come up to us if you have questions, access this, look at it, access the slides. Thank you for being with us, and so long for now.